Hello, everybody, and welcome this evening. We'll just give everybody a few more moments to come on in. We have some people on, but just give another minute or two for people to join us. All right, welcome this evening. Thank you very much for joining us for our presentation on long COVID. My name is Nicole. I am a board director for the Ontario Kinesiology Association. I am happy to welcome James Sesford tonight, PhD and a registered kinesiologist. James is also a research associate at the University of Toronto and is a co-investigator on a grant from Long COVID Web, seeking to design a model of family-centered care for long COVID in Canada. James has been involved with volunteer organizations seeking to raise awareness and advocate for issues relating to long COVID. He holds a graduate degree related to behavioral psychology and physical activity adherence for chronic conditions such as chronic pain, arthritis, and multiple sclerosis. At the Rehabilitation Science Institute at the University of Toronto, James is currently a member of the Rehabilitation Sciences Advancing Equity, Accessibility, Diversity, and Inclusion Committee. We are happy to have James this evening to offer an excellent presentation on long COVID. And I'll pass it over to you, James.
Okay, thank you very much. I am happy to be here. Good evening, everyone. Or if you're watching this on a recording later, I will give one spoiler in my work and in the presentation, and that is that the overarching theme tends to be that healthcare providers have a relatively low understanding or awareness of long COVID. So just being here today, we're making some progress. So I appreciate that. Now, let's get started. Here we are. Um, Here are my disclosures. Some of this was discussed already. My funding comes from Long COVID Web right now, and I've done some volunteer work with Canadian COVID Society and Ontario School Safety. I'm speaking on my own behalf today, not on any particular organization or institution. And I would say I've had less severe experience with long COVID, but some experience with that myself. So to start with, there's a lot of foundational sort of awareness stuff to cover with COVID itself and long COVID. So we'll start there. As mentioned, I'm involved in kind of EDI committees and want to bring some of that into it, then get into what can kinesiologists do and get into the take-home messages. And I have a lot of good resources to share. You can ask me directly for those, or I'll probably share the slides with OKA as well. So let's get into the background. First major question, is the pandemic over? So the World Health Organization would say no. There is this statement from May 2023 that is usually cited as people's interpretation of the pandemic having ended, but what this was an end to the public health emergency of international concern. And you can see in their statement underlined, this does not mean the pandemic itself is over. So the statement was explicit in not saying the pandemic was over at that time. By the end of 2024, the WHO was speaking to the number of fatalities from COVID, which conservatively was said to be 7 million, but they estimate is at least three times that and suggest we cannot talk about COVID in the past tense. It's still with us. It still causes acute disease and long COVID, and it still kills. So we cannot afford to forget about it. And why might this matter? So this is referencing a letter in the British Medical Journal, and that suggesting the world is post-COVID actually contributes to unwitting shift in research priorities. So this is a statement from the US Department of Health and Human Services proclaiming they will no longer waste billions of taxpayer dollars responding to a non-existent pandemic that Americans moved on from years ago. So that is an interesting statement because the reason Americans might believe that they've moved on from the pandemic is the government will have told them that it's over, right? So you make the statement that it's over, you manage to influence the public's perception and behavior to believe your statement, and then point to their belief as justification for the original statement. So it's a self-fulfilling prophecy. So I just want to point that out. But to continue on with the letter itself, aside from the research priorities and funding, things like that, and they actually state that, using the language like post-COVID, post-pandemic, or even back during COVID also obscures risk perception in addition to the change in research priorities. So there's a tangible impact to that. So what can we do? We can simply refer directly to what we mean when if we're speaking to an early phase of the pandemic, speak to the year that we're talking about, if we were still in the emergency phase, or related to the public health response, like when there were stay-at-home orders in place where you are, et cetera. So there are alternatives to avoid sort of describing this in the past tense. And it's not just a matter of semantics or technicalities, really, like quantitatively looking at wastewater in the US in this example from 2020 to this month. It's pretty hard to find a spot on here where you'd identify the pandemic being over. This is wastewater transmission of COVID. So, especially looking at 2023 May, there's nothing since that point that looks like a major dip or absence to me. Um, Contrary to what people kind of perceive is that 2020 and 2021, with the exception of the end of 21, which would have been Omicron, the actual wastewater levels were lowest at that time. To be fair, there were more fatalities, so it wasn't spreading as well. But suffice to say, up to now, there are still major peaks of at least 1 million cases a day in the States. Canada, unfortunately, this doesn't go back to 2020 to get the full picture, but this is Canada and Ontario in purple. And again, there's not really a point where it looks like, least of all in 2023, as if you describe this as over. So just looking at that. So if we're talking about transmission, you have to have COVID in the first place to get long COVID. So just, I am going somewhere with this, but understanding these continued high rates of transmission, requires understanding how things are transmitted. So if upwards of 50% of transmission is asymptomatic, then it doesn't really make sense to sort of have these approach of, okay, well, I stay home when I'm sick, or I mask when I'm sick, or et cetera, when I'm sick. That doesn't really correspond with the way it transmits. It's primarily airborne and hangs in the air for hours. So while hand washing is a great practice in general, it's not really correspondent to the physics of how this particular virus transmits. In terms of reinfection, this can happen after vaccination. These are called breakthrough infections, so this is not uncommon. So it doesn't really make sense to have sort of a vaxxed and relaxed attitude. And finally, this idea of immunity debt, where if there were public health measures in place, so people got sick less often, and therefore they're going to have to pay that back later and get sicker. Doesn't really make sense if you think about wanting to get sick in order to not get sick. And I can't recall who I can attribute and credit this to, but I heard someone compare this to getting pregnant in order to have as a method of birth control. So for a period, sure, you won't get pregnant again, but you're kind of defeating the whole purpose. So these are just important notes about how it's spread, the prevalence of spread. And last thing before I get more into long COVID itself is just that COVID infections come with a number of other consequences apart from long COVID that none of us would really want to be involved in, right? So there's immune dysfunction even after mild infections. there is increased risk of heart attack and stroke. And this third point, granted, is for severe cases, hospitalization of COVID, but that's 2 decades equivalent of aging in terms of cognitive deficit and contributions to cancer, metastasis, and resurgence. So, numerous reasons to avoid COVID infections aside from long COVID. But I'm going to get into using the term long COVID today. That's the sort of patient and person with lived experience generated term. So that's what I'm going to stick with. But all these other things mean the same thing. They're more academic terms used in the research, but they all mean long COVID. So that's what I'm going with. This definition expands a little bit on the World Health Organization one. It's not inconsistent. It's just um, more detail. So essentially, you get COVID, and then you have persistent symptoms at least 3 months after that, and those can be continuous or they can come and go. So that's essentially the basic version. They have a good graphic though along with it. So this first point, of course, you have to have COVID first, but it can be of any severity. You could even have asymptomatic COVID infection resulting in long COVID. And in terms of diagnosis, you're not required to produce like a PCR test or rapid test even, but it does happen as a result of infection in the first place. The second point, it's already been covered that it's at least 3 months following that infection. Now, there are over 200 symptoms that can present in long COVID, and there are no specific ones that are required to be present in order for a diagnosis. So it's a highly variable condition in terms of what they're presenting with, and the severity it can be mild to severe. In terms of the equity piece on the bottom left, I think the overall point there is to express that there's no one who's not susceptible. That's important. Anyone would be susceptible to long COVID, but I will come back to this in a way because there are people who are more susceptible than others. So you can't be, young enough or fit enough or anything enough to just feel that you're not susceptible. But groups like women, for example, tend to be more affected than men are, and there are other differences such as that. And in terms of functional impairment, yeah, this can be impacting all kinds of important occupations in people's lives, from school, work, relationships, things like that. So that's a good complete source on definition that is just more comprehensive than the World Health Organization one. In terms of common presentations, brain fog is kind of a mild, doesn't really capture the extent of it. Brain fog itself constitutes cognitive dysfunction and problems with memory and things like that. Other common symptoms are dizziness, gastro, palpitations, and things like that. And these bottom two conditions are conditions that they're diagnoses in themselves and predate COVID. They're not only related to long COVID, but I'll get more into them because they're common. And in the sort of the clinical recommendation area, I'll focus on those. So postural orthostatic tachycardia syndrome, or POTS, has to do with, regulating blood pressure and variable heart rate and things like that. So dizziness and fainting are components of that. And the MECFS diagnosis commonly comes with post-exertional malaise and extreme fatigue. So that's a feature there that's highly relevant for KINS. And to speak to how common or not this is, a 2024 review estimates 400 million people worldwide with long COVID. And in the US, a recent paper identified at 6 million children in the US. That makes it the most common chronic health condition, even ahead of asthma. And this is some modeling data that was presented last year at the Symposium of Long COVID in Canada. And this modeling suggests that 1 in 3 Canadians may have long COVID by next year, 2027. So can't dismiss this as rare by any stretch. This is Statistics Canada data on multiple reinfections and a proportion of people reporting long COVID symptoms with those. So at one infection, you can see it's in the neighborhood of 15%, and by 3 infections, it's nearly 40%. So repeat infections are higher risk. And this compared actually the rate from first infection to second infection in children and found the rate doubled. So we're not simply saying it's, a 10% chance every infection and you're just continually rolling the dice on repeat reinfections. Subsequent, like this second infection is actually double the risk of the first infection in this case. So that's a good point to get into the EDI issues as kids constitute one of the vulnerable groups. So I'll go a little bit across these topics: children, financial cost, racial disparities, accessibility in healthcare is especially relevant, and then gaslighting and stigma is highly relevant too. So why, in the College of Kins, Ontario, it's a core competency to foster EDI in all professional interactions. I just wanted to touch on that. And in terms of children, this is a quote from Violet Affleck speaking to the United Nations last year. The link's there. I encourage you to check it out. It's just about 5 minutes, but it is neglect of the highest order to look children in the eyes and say, we knew how to protect you and we didn't do it. So this, we have data showing upwards of 70% of transmission comes from schools, and kids don't really have agency, right? None of them are delving into the literature like this and then setting the public health policies within their household or their classroom or things like that. Kids are counting on the adults, their parents, their school admin, things like that. So it's an EDI issue there for children. Financial cost, I'll get into pacing a bit more later, but that's a very common symptom management strategy, but it comes with significant costs. So if you're able to modify your work to reduce, or you have to stop working, obviously it's a reduction in income. If people are using electronic devices for monitoring, like an Aura or body battery type things, that's coming at a cost. The overall trend has been that the public funded long COVID clinics are closing and the private ones, then they are coming with a cost. And when you have long COVID and you have reduced function as a result, you tend to be more attentive to preserving what you have. So getting COVID again can send you back even further, even lower functioning. So paying attention to, avoiding reinfection. We don't have free tests anymore in Ontario, paying for masks, paying for HEPA filters, and sort of taking it on all as an individual endeavor rather than a public health one comes with costs as well. In terms of racial disparities, this is a study that looked at views of white US residents when they were presented with the data on the persistent inequalities from as a result of COVID-19. The unfortunate thing is it actually reduced their own fear of COVID-19, reduced their empathy for those vulnerable to COVID-19, and reduced their support for safety precautions. So where you might have hoped people would identify themselves as having power and privilege and seeing where there is injustice already, wanting to leverage your power and privilege. In this example, it seemed like the attitude was, well, it's not so much a problem for me, so I'm less supportive of trying to solve the problem. So a lot to contend with in terms of EDI. Getting into the healthcare specifically, there's really two factors. The big one is infection control. As I mentioned, people don't want to catch COVID again when they've had a reduction in function due to long COVID. So preventing reinfection in those spaces is key. I'll get to some data on that in the next slide. And then the other piece to that is symptom factors. So if it's an energy limiting condition, accommodating that can be quite important. So it can take a lot out of person to do the travel and in person, especially if there's an alternative available, if it's feasible to do virtual. And the attention, even just the attention required for driving, sort of can be draining. And so trying to not overburden people, and I'll get more into that in assessment and things like that. But looking at the data for hospital-acquired infections, granted this one is Wales, I'll do Canada next, but if you look at the number of inpatient cases of COVID and of those, how many acquired the infection in hospital, that's 79%. So if we're going into healthcare settings to improve our well-being or, recovery or things like that, and we're coming away worse off. This is obviously a huge problem. Canada, it's not quite as bad. As of last month, it's 44%, but I don't think that's acceptable. And what happens is people who are more susceptible, more vulnerable, are tending towards delaying or deferring routine healthcare because recognizing the risk inherent to going, are they actually going to be, coming away better than they were or worse than they were? So that's a consideration people are contending with. As I mentioned, sort of people's like capacity for their energy levels and things like that. You don't need to read this example, but just to note that it's very text heavy. This is a recruitment poster that we had for a study earlier, and it's extremely text heavy. We thought this was good to give everyone their kind of one-stop shop for all the info they might need. But when this got in the hands of people with long COVID, like the spouse would get in touch and say, I gave this to my partner with long COVID, and they took one look at it and said, I can't read this. Like, it's just too overwhelming. So, mistake on our part that we should have been prepared for. And we went back to the drawing board, rejigged the thing just to be more basic, less overwhelming, and this got was received much better. So learning as you go, listening to people, what they're telling you, and trying to improve. Gaslighting and stigma is a major problem. It's commonly reported among people with long COVID and their families, and it does originate from healthcare workers themselves, but unfortunately from their families and the communities as well. So this can be telling people it's all in their head. The long COVID isn't real, or even COVID's not real. You're just deconditioned and need to exercise is a highly relevant one for us as kins, because I know, like, I come from a place where if anyone can exercise, they should, and more is better. That's been my sort of understanding all my life, but this is an exception here. And these kinds of things can come from low understanding of long COVID, but it's not in the scope to solve it in this talk, but it's also related to a resistance to understanding long COVID, unfortunately. So I would compare it to like an anti-vax messaging campaign kind of thing. So you're probably not going to convert everybody just simply by giving accurate, up-to-date information because it's tied into other things, identity, ideology. It's more complicated than that. And so it plays out like this is a quotation from a healthcare worker in one of our studies. I'll say that a lot of people have had it with COVID, don't necessarily care about it now, frustrated with it and all the PPE that we have to wear. So a lot of people will, even if it states outside that there's precautions outside the door, they don't do them. So this is not a knowledge gap. This is like infection control has noted for this person, special precautions need to be in place, and people are choosing not to do it. So it's not just a knowledge gap, but there is certainly a knowledge gap, and that's easier to attend to. As far as the stigma and that kind of thing, this is a really interesting paper from last year. I'd encourage you to go and find it. COVID is airborne AIDS, provocative oversimplification, emerging science, or something in between. I can spoil for you that it's the something in between. They are not directly the same thing at all, but this visual abstract is a good summary in that they start off saying how they're different. They transmit differently, of course, sexually versus airborne, and the length of time to progression to AIDS is in decades, and long COVID is a matter of weeks or months. The middle piece, if you're really into the immune system mechanisms, definitely read it. Both result in immune dysfunction, but the mechanisms aren't the same. From there, yeah, both pandemics marked by stigma and inequities and delayed response. So if the first time around in HIV, maybe people are suggesting it's only a problem to worry about for men who have sex with men or intravenous drug users or whoever, they're stigmatizing marginalized groups. And we're doing that again here with suggesting that COVID or long COVID is only a concern for people who are quote unquote vulnerable or elderly, etc. So getting into what can we do? Number one, for sure, is understand long COVID better, as well as avoiding making people worse, right? Avoiding reinfecting with COVID or causing symptom crashes with symptom inappropriate care. I am going to go through those two conditions a little bit more and speak a little on advocacy as well. So, in terms of understanding long COVID, this is a quotation in our study from someone with long COVID. So, I had it for a year and a half before I knew that there was a thing called long COVID. So, people are not, this is delaying diagnosis and everything. People just aren't thinking about it. So, if you're even seeing people who are not identifying to you that they have long COVID, but you're picking up on this constellation of symptoms, um, lots of new fatigue, brain fog, those kinds of things, have it on your radar at least. Consider COVID, have a discussion with the person. Have they had an infection in the last couple months or that kind of thing? Just get it on people's radar to discuss and pursue if it's appropriate. And healthcare providers, as I said, can be a big source of stigma and gaslighting. So it's worth its weight in gold when someone with long COVID finds a provider who is understanding, informed on long COVID and validating as opposed to gaslighting. So this will earn your trust. And of course, as I mentioned, relating to diagnosis and treatment and avoiding inappropriate treatment and worsening people's condition through reinfection. This is from a healthcare provider just commenting on how they'd love to see it in the curriculum. Their data at the time they're speaking to 1 in 9 Canadians having it. And would there ever be a world where clinicians don't learn about diabetes or hypertension? There's not. So how come we're not doing this with long COVID? Now, in terms of the infection reinfection, I want to address this Cochrane mask review from 2023, and it was widely misinterpreted to mean that masks don't work when the actual conclusion was inconclusive. So it was to the extent that the editor-in-chief published an apology and sort of a correction on that. And now there's another link here if you're interested to pursue why it's not even really an appropriate methodology to go through randomized control trial and that sort of thing. It's a physical engineering intervention, similar to like a seatbelt or parachute or something like that. But in any case, there's a more modern review which had the main findings here that COVID is airborne, as I'd said. Masks are effective. Respirators are more effective than surgical or medical masks, which are more effective than cloth. Mask mandates have been effective. The non-adherence to masking is linked to ideology and mis or disinformation. That's sort of similar to what I had said about the information gap not being the only issue, that there's other stuff, a resistance going on. There are contraindications or disadvantages, like if somebody can't hear and needs to lip read. So acknowledging those as well as environmental impacts. But I would suggest that if we were to reduce the burden of long-term illness or hospitalizations, we might also see a reduced impact on the environment. So as far as masking, the CSA, if you're familiar with them, had a new draft standard last summer, which would be for universal respirator use in healthcare settings. That is not finalized, but that's in the works. So it may be a moot point if this comes into play and healthcare settings require universal respirator use. But in the meantime, the evidence is there for it. The World Health Network has a petition to the WHO to emphasize respirator use and that these sort of baggy blue surgical masks are not appropriate PPE for airborne virus transmission. That's picked up by like The Guardian and Forbes. And so progress is happening, but we don't really need to wait to be compelled. We can go by the evidence and ethics. So to provide accessible care, like I said, avoiding infecting and reinfecting, masks are a great way to start with that. Clean air, like ventilation and filtration. I'll have some links in the resources as to how to assess that if people are interested for their space. Um, Testing. Yeah, a positive rapid test should be interpreted as you are currently contagious. And if you're testing to return to work or contact with people, two negative rapid tests 24 hours apart would be a fairly reliable way to do that. Staying home when sick and advocating for this kind of thing in your clinical setting. So, like a bridging topic, of course, virtual service delivery, you won't be reinfecting anybody in that case, but it's also, as I mentioned earlier, to address symptoms and sort of the chronic fatigue or post-exertional malaise sorts of things, avoiding needing people to travel and that sort of thing, in addition to limiting sort of the length of forms or limit the extent of assessments to just what's necessary, remembering our sort of learning curve with that poster example. So in terms of assessments, if you can get away with submax testing over maximal testing for your purposes, that's advisable. These are sort of like the broad recommendations before I get into the POTS and the post-exertional malaise stuff. But yeah, can you manage with sort of a submax predictive assessment and collaboration with the patient on selection of patient-reported outcomes, including goal setting, is advisable. So there's this form, the patient-specific functional scale, which has room to quantify multiple different goals. And this is important because long COVID is unpredictable. You can have setbacks, and you don't want to be sort of focused on just one thing necessarily. And you want to be able to pursue multiple things so that the motivation is not, too upset over the unpredictable nature of the condition. So something else that's worth assessing, though, is the social history or family-centered care, because this condition can often require a lot of support from family or chosen family, whoever that may be. So trying to determine what that context looks like for the person. Is there anyone even present who's involved in that capacity as a caregiver? And if so, what's their capacity and willingness to support? Is the person with long COVID themselves a caregiver or parent? So understanding what their life roles and demands are. And as I said earlier, sometimes the gaslighting and that sort of thing can be coming from the family. So assessing that is part of that capacity and willingness. And if the person with long COVID, they may request this, but if they want, it can be of value to help educate the family caregiver. Certainly, if you even need to address this level of getting them on board with that it's real and sort of what the course of it looks like, that would be valuable. Expectations surrounding recovery are also really important because this is something that for KINs are really looking at managing quality of life and symptom management and things like that. It might not look the way some of your other populations look, where you expect, a linear trajectory back to work kind of thing. Having realistic expectations around recovery is important because a lot of resentment can come within a family if there's a belief that the person with long COVID is just lazy, or they just need to try harder, or the condition's not even real, right? Then the extra work that gets put on the caregiver, household tasks, financial responsibilities, things like that are harder to stomach if they don't understand that their loved one really can't um, fulfill the roles that they used to fulfill. So if you've got the caregiver on board and they're wanting to learn, then instrumental supports that might be things you would do with other conditions, like how to transfer if they're using wheelchair, things like that, just nuts and bolts, or like I said, memory can be a big thing. So having someone who's involved as a family caregiver who can be there to help retain what you're discussing, your appointments, or help be another just source for your assessments, another set of eyes and ears to be able to notice progress or lack of progress, things like that. So, of course, I mentioned earlier this, if desired by the person with long COVID, means having their consent for this and revisiting that regularly. Um, as I just mentioned, yeah, this is important in terms of the expectations. The full recovery may not be realistic, but you can try to focus on quality of life and symptom management. So in terms of the specific presentations, the couple examples that are common I want to go through: post-exertional malaise or PEM. So this isn't a matter of being deconditioned, although it's chronic fatigue. It's easy to let your kinesiology background lead you there. There are actual physiological changes in the muscles that are distinct from bed rest controls. So there's this study here where people were on bed rest for weeks, healthy general population without long COVID were on bed rest and compared to people with long COVID. And although both experienced changes in the muscle physiology, they weren't the same changes. And it just shows that it's a distinct sort of thing. It's not just being deconditioned. So there is a questionnaire out there that you can use, the DePaul Symptom Short Form Questionnaire, to screen for post-exertional malaise. And the next slide, I'll show sort of a clinical pathway, which is also on the Keen website, I think, linked there. But it'll sort people though for you into no post-exertional malaise or like mild, moderate, or severe. And in the severe case, you're just not going to be, it's going to be contraindicated to exercise. And so pacing is a critical intervention that is used for everyone. That's um, they often use the term energy envelope or like budget. So learning sort of what you can do with that, because the crashes they might experience take place maybe a day or two later. So learning how to connect those dots of what we're doing that led to it. Sometimes they're quantitatively monitoring it, like I said earlier, with devices, but learning to monitor their expenditure and identify triggers for crashing and things like that are important, and borrowing even from occupational therapy, looking at energy conservation. If they're cooking or working in the kitchen, having a stool near the counter or vacuuming seated is something I've had people talk about. So those kind of strategies can be worked in when exercise is not contraindicated or just in general looking to conserve energy. So you don't need to see every detail on this. Like I said, it's on the Keen website. I know it's small here, but the main point is you get sorted into the three different categories. And the no PEM with the green heading is essentially traditional exercise prescription. On the far right, as I said, it would be contraindicated to exercise. So it's an emphasis on like relaxation and pacing. Pacing is the arrow on the bottom, so it's connected to both mild and severe PEM. And there is sort of a modified exercise prescription in place there for the mild and moderate. So using that questionnaire to sort and then approaching it as appropriate. Now, POTS, I think I mentioned earlier that, yeah, that messes with blood pressure, heart rate regulation, things like that. So goals there could be increasing venous return and or blood volume. And you can do that with increased salt intake, increased water intake. Exercise can help with those things as well on compression garments. If you would like to see, there's a case study here of a teenager, and this is a physiotherapy, but they're using essentially the same kinds of interventions, and you can witness sort of the push and pull, the ebbs and flows there, because again, it wasn't a linear recovery, but to get a sense of an actual case study, I've linked one. In terms of exercise considerations, you'd be concerned about potential balance issues, dizziness, falls, so things where you can spend more time on a mat and staying in place, not up and down, which would be a problem, but doing mat work for um, a period of time, as well as seated cardio would be another approach. And there's a unique position as allied health or like rehab clinicians, whereas you'd see people much more than their family doc traditionally and for longer. So they might be going to their family doc looking for support with things like disability forms or corroborating just what their capacity and their function is. I think we're better positioned for that kind of thing. So helping with documentation and playing that role. And there's just a quotation at the bottom of how appreciated it is when a informed clinician is listening and supporting through this. And this is not an Ontario example, but in this example, the province sort of they have to work around using even the COVID word because then they know they're not going to be approved. So there are a lot of hurdles here. So being an ally is a great help. Now, if you're doing any research, just a quick note, there are patient-led research scorecards that cover these topics here. So if you want to involve people with lived experience in your research and do a better job than just sort of a checkbox or tokenistic approach, these categories are laid out. This is just a sample here of what they look like and how they're scored so you can assess your plan and for including people with lived experience. I have links to those scorecards, but that's a useful tool for anyone engaged in research in the population. Take home messages. Again, ongoing increased understanding of long COVID is important for oneself as a clinician, amongst colleagues and in the community. Being that person who is informed on long COVID and believes and validates people is also much appreciated in this population. And then just trying not to make things worse. As I said, unfortunately, there's not like an approved therapy that's a cure, and it might not be realistic to expect a full recovery, unfortunately. So certainly avoiding making things worse by getting someone infected over again and setting them back, or exacerbating symptoms by just sort of pushing through and ignoring like a post-exertional malaise kind of thing would be very important here. If you're interested, I'm talking about so much about the awareness. There's a Toronto conference in April, and this researcher did the bed rest study I mentioned earlier. So feel free to look into that if you'd like to. It's a full day thing. The day prior, there's just a lunchtime thing. Either of them are both virtual and in person as well, I should say. So you don't have to be there in person, but you could. And this one's more about rehab assessment and measurement in long COVID, so may be of interest as well. In terms of the resources, I won't hit every one or go into detail, but the second one, the Rehab Management of Long COVID, is a textbook that I drew from that is just out last September, so quite up to date, great resource. The competency exam is like an online quiz, just if you want. Sometimes those are fun and can be educational, see what you know or how your knowledge matches up with the research. The long COVID web echoes are like a clinic, like community of practice. So you can, at the front end of the long COVID web one, there'll be like a didactic lecture type piece to it. And then the second half will be a case study. So if you want to get in that space and speak with other people and get to ask questions and brainstorm on actual cases, that is a good way to do that. If you want, instead of just kind of the detached arm's length, like numbers stuff, like I'm presenting, and you want more of the personal touch, this study at the top is video snips of various participants actually describing their own, lives and personal experience with it. And as I mentioned, there's that piece. Of course, it would be great to get just consistent and reliable messaging and awareness and education out there, but there's still going to be a little ways to go after that on the sort of the psychological resistance and that kind of thing. So this is another behavioral psych guy, Dr. Michael Herger, doing a lecture sort of or conversation rather on what those barriers look like and strategies. So the rest of the resources are just kind of things I mentioned in the talk. I don't think I need to touch on them, stuff relating to the ventilation, like I said, for clinical spaces, things like that, and links to measures, that sort of thing. So I'm going to leave this up for the moment. If people want the slides later, they can certainly ask me, but I think I'll send them along to OKA and they'll probably get distributed there. Any questions for any reason, yeah, you can reach out by email, but that's, yeah, that's it for me for the moment.
Thank you very much, James. That was an incredibly interesting presentation. It's impressive how much information there is out on COVID and long COVID, especially because we've all lived through it. And it's interesting to see how prevalent it is still today. If anybody has any questions, could you please go ahead and put it in the question and answer box, and I will go ahead and read those questions off. Um, I guess I can start off with one quick question that I had was, are we getting anywhere closer to being able to solve or help resolve long COVID? Is there being any research in that? Because the numbers seem pretty staggering for the amount of people that have long COVID.
I wish I could say yes. Not being in the medical or pharmacological space myself, I think that there would be maybe more insight from someone like that. But certainly in the rehab space, we're kind of working with symptom management at this point, and there are many trials going for drug therapies and things like that, but no bright light at the end of the tunnel for now. And so, looking at that sort of projection of potentially 1 in 3 Canadians by next year. Um, the prevention's pretty key as well, and it's
Mhm.
relatively inexpensive and non-invasive to manage that for the time being.
For sure. And for those of us that are kins and are working directly with clients that maybe have long COVID, or maybe they're not sure that they do, what would be one of your main takeaways for us? I'm thinking maybe somewhere along that pacing. So if we're working with somebody, making sure that we're working within their abilities for their particular day, maybe different time of day, and making adjustments on exercises that we're giving for them.
Yeah, I think pacing is a very common symptom management thing that everyone probably ought to know and implement. And yeah, be that safe person. Another point I guess I didn't get to, I'm glad we have time. I wasn't sure how long I'd take, but it's probably common, at least when I'm doing certainly interviews with people with long COVID, that a lot of the things they're sharing about just the physical side can be traumatic. The impacts in their family and their work can be traumatic. So you are hearing a lot of traumatic stuff, and so knowing to stay in scope, and being an attentive, empathetic listener, but not stepping into the mental health realm, knowing when to refer for that as appropriate, I think would be important, as well as managing your own mental health when you're exposed to other people's trauma at that level. Certainly, if you're in like a long COVID clinic and that's the amount of people that you're speaking with. So managing that for yourself to avoid burnout as well.
Mhm. I did have a comment in the question and answer, and it was just about getting a copy of the slides, which I think that we'll be working on doing that. And then working with some of the resources to help with diagnosing of long COVID cases. Obviously, that would be out of scope of practice for us as KINS, but some of those resources we would be able to provide for our clients potentially and be able to help them go through them. And I think you had said too at the beginning about putting it on people's radar.
Yeah, I think so. Just consider COVID is something potentially helpful, and certainly it can share the slides. The OKA like Keen site does have in the best practice guidelines some good resources there, and you can observe and document essentially that sort of limitations in function, for example, things like that. Maybe the disability body doesn't want to accept just the KINS notes, but if you're collaborating with the family doc, maybe that, like I say, they've got less time. If you've got the starting point of here's what's happening, and they can bring that to their family doc to sort of certify or pass on,
Mhm.
could be
I
of
find
help.
that for sure with clients because we see them a lot, like you had said, more often. And
Yeah.
so we can kind of get some of those kind of day-to-day symptoms. I think that's an excellent point.
Yeah,
The
they
next
tend
question.
to
Oh, go ahead.
So just really briefly, like if they
Hmm.
have an appointment, they tend to pace for the appointment too. So to
Mm,
be in this room with the doc, they've anticipated they're going to need to get out of the house and do that. And so the doc might not be witnessing them at their most symptomatic and that kind of thing. So yeah.
that's good. Good point. With long COVID being a little bit new, how are insurance companies dealing with workers who are unable to work due to the condition, but are being denied long-term disability?
Sorry, how is who dealing?
So how are the insurance companies? Do you have any information on if the insurance companies are managing or if they're providing support for people that have long COVID for like long-term
I think
disability?
it's quite variable. There's not a consistency, I don't think. People are reporting to me like this latest study is across Canada, so it's a mixture of different provinces and whether they're seeking the provincial versus a private insurance thing. But there's a bit of a luck of the draw. There's a large volume of work usually in the documentation that needs to be provided. So that in itself for an energy limiting and cognitive dysfunction kind of condition is a big hurdle. So as I said, one of the strategies that people are using is to just not say COVID if they can avoid it. If they can speak to saying, well, I have POTS or I have something else, it's sort of an unfair extra labor to have to do that. But yeah, I don't think there's a consistent acceptance or anything like that.
Okay, perfect. All right. I don't have any other questions right now in the question and answer box, but we definitely do appreciate you coming and providing all that information for us tonight. Like I said, it was very interesting, and we thank you very much for joining us.
Thank you.
Have a good night, everybody.